buccal site, which obviously is the case with almost everybody today, should we fill this gap? And the final answer for our patient, and why we are concerned about filling a gap or not and bridging the jumping distances, can we maintain the buccal tissues over time? So this is what we try to answer. Placing immediate implant despite an infection. People obviously do not have a lot of problems placing an immediate implant in a previously infected site, but sometimes you hear people talking about, you can't do a socket preservation procedure because it was infected. So sometimes I ask myself, what's the difference for those people between a biomaterial and a titanium implant? Because both are somehow brought into this infected socket. So let's review when we extract a tooth. For me, the indications to extract a tooth before I place an implant then is if a patient has a chronic or acute apical problems, endo problems obviously. Number 3 and 4, if the patient has chronic or acute problems with periodontitis, this is another reason to extract a tooth. And finally, if your tooth is broken, fractured or completely rotten, you have to take it out. Any of these 5 indications will leave you with an infected socket. Because by definition, be it more chronic or more acute, bacteria are involved in these 5 indications. If none of these indications is there, you would have a clean socket and you actually could, if you want, maintain the tooth, do a crown lengthening procedure, maybe orthodontic extrusion, improve the ferial, make a posting cord and make a crown. If you want, you could save the tooth. But with these 5 indications, you have to extract the tooth, and by definition, there is always bacteria involved and the socket is infected. Meltzer has already shown in 2012 that implants heal in these kind of infected sockets without any problems. The question we have to ask ourselves is, where are those bacteria we are afraid of when we place immediate implants with or without bone grafts in the buccal gap? Where are those bacteria located? Are the bacteria inside the tooth or outside the tooth? Yes, of course. If you overlook a canal, a root canal, there will be bacteria in there. You have leakage of bacteria. And calculus and tartar on the outside of a root is also bacterially contaminated. So yes, this is where the bacteria are. Are the bacteria in the granuloma, in the apical radiolucency? Of course they are. This is the battle zone. This is where the bacteria fight with the immune system, the rank ligands are activated, the osteoclasts coming in. This is the battleground of what's going on there. So yes, there are bacteria. But are the bacteria inside the bone? After you've extracted a tooth and curated the socket and cleaned it, maybe using a certain disinfection protocol, are the bacteria still there inside the bone? When you hear that sound, when you scrape on a good bone quality after all the soft tissue is gone? Well, no, they're not in there. Actually, I try to find in the literature if there's bacteria still there. To give you the answer first, if there was bacteria inside the bone, you would have an osteomyelitis, and this is what you do not have. Well, I found a nice publication, Nelson and Thomas in 2009. They wanted to find out if there are still bacteria in that area when you place these implants. And you know what they did? They had 32 patients, and they took samples from them, from the bone. And these samples they used, 56 samples were from late implants, so the tooth has already been extracted long time. Now they placed the late implant and they used and looked at the bone if there's still bacteria inside. They had 16 samples from sockets, that's what's interesting for us, from immediate implants, and 5 samples from failing implants. Overall, 32% of those samples were contaminated with bacteria. They made an assay and looked which kind of bacteria to find out their names. And the contamination was even in the late implants. Harvesting the bone was 21%. There were bacteria inside. In the sockets, you had 69% of the sockets infected, and all of the failing implants had lots of bacteria in there. However, the amount of bacteria was not really specified there, just the number. This is the only literature where we see, yes, bacteria are still involved, even in late implants, but obviously that doesn't make clinically a big difference. And what disturbed me a little bit, the authors, Nelson and Thomas, they're both from a university clinic in Australia from a gynecological department, so I wasn't sure if when they transferred the samples from one department to the other, that maybe something got mixed up. But anyway, this is the only literature we have on that topic, which gives us not a real good hint. So let's go back to our field. In 2017, we have a retrospective study on the topic post-extraction implant placement into infected versus non-infected sites. And let me summarize this, quite a lot of implants, 572 implants, the retrospective study. Non-infected sites, infected sites, follow-up for both, 50 months, so that's a good amount of time, 4 to 5 years for both groups. And look at this, how they defined chronic infection. Chronic infection in their study was the patient had swelling, fistula, probing depth, pain and radiolucency. This almost sounds to me like an acute infection. I mean, the only thing which might be missing is suppuration and litters of pus flowing away from the site. So this is what they call a chronic infection. And if we look at the pure survival rate of the implant, it was basically the same. So obviously we can say, yes, osseointegration, that's survival rate. Osseointegration works in those infected sockets, and more or less every tooth we extract has some kind of infection, so there doesn't seem to be a problem for the process of osseointegration. So we can check on that topic. How about primary stability? How can we get primary stability? What do we do to get primary stability? You see Pablo's presentation a few minutes earlier. Well, also there we know some things. Implants will heal and osseointegrate even if they are very loosely in the bone. In Kobo Vasquez's publication, they had no primary stability, but they also integrated. In Michael Norton's presentation, they had a low insertion torque, but still all also integrated. Of course, it depends on the load. When you look at these two clinical pictures there, one is loaded, one is not loaded. And there you have an advantage with an implant which you can place deep inside the bone, because the deeper you go, the less load is there for your implant. So of course, if it's not primary stable and loaded at the same time, you're going to fail. But if you do not want to load it immediately, or if you do not want to provisionalize it immediately, and it has no primary stability, or a very, very low primary stability, it still will osseointegrate. A spinning implant will osseointegrate. The surfaces are good enough. It just needs time of unloaded periods. So it depends on the load. If you want to go for immediate restoration, it has to be very stable. If you do not want to go for immediate restoration but still place an immediate implant, it will heal. The deeper you can place it, the easier for you. And of course it depends, as we've heard also from the implant design, you can go for under preparation of changing sequences of the burrs in some systems, or you have a design like the progressive threads of the ankylus, which make it, per definition, relatively easy to get a good primary stability all the way down there in that areas where you have the wider threads. So that helps a lot in maintaining primary stability if you need it because of immediate restoration. So, which diameter? 15 years ago, we heard people on stages like this saying, fill the gap, fill the socket with an implant. Take a wide diameter implant to get a good primary stability. Well, nobody obviously will place today a 5 or 6 millimeter diameter implant in a center incisor socket in the maxilla. Everybody will take a small diameter and go off to the oral site. And although everybody agrees that we do this, still keep in mind why people do this, because sometimes the reasons are mixed and not clear. There is two reasons. Some have a fear of the microgap. If you have a dirty microgap, loose connection, stinking abutments, if you have smell when you take off the abutments, it's a loose microgap. This microgap will exert a 1.5 millimeter influence on the surrounding bone. Mesiodistal, this is what created the distance rules of 3 millimeters. It's based on dirty microgaps. And the same thing happens to the buccal side, of course. So if you have a dirty microgap and your remaining bone wall is 1.5 or less, and you place the implant level with the bone, you run the risk that the disc-shaped defect to the buccal creates a midfacial recession. That's one thing why many people go off. The second thing is the fear of the bundle bone resorption, and that's independent of the implant system, because after every extraction, we should be prepared to lose some bone due to that bundle bone effect. I don't want to go into details because all of you know this. Jan Linde has done tremendous research on this topic with his group in the last 10 years. So that's something independent of the implant system, what you have to keep in mind. And these two things together lead to the fact that people say, yes, we use a smaller diameter, and this causes the buccal gap. And now we're talking about the jumping distance, because if we didn't use smaller diameters in the anterior area, we wouldn't have to talk about filling up that gap or not. We would fill the gap with an implant. So should we fill the gap? What about the jumping distance? Yeah, if you look into the beginning of these terms, it comes from orthopedic research. However, most of the classic research on the jumping distance, believe it or not, is based on animal research, where they didn't have sockets, but they created surgically osteotomies which were wider than the implant diameter. And then they placed a small diameter inside and looked what happens to the jumping distance. But creating surgically an osteotomy with a lot of bleeding and sound bone, in my opinion, is dramatically different from having a socket possibly infected with remaining Sharpay fibers in it, and then looking at the jumping distance. So most of that basic research you see there is in surgically created jumping distances, and thus not really valuable for our answering process. But we have some things to look at, and I like this study here from a Japanese group. They looked at the mid-facial bone height and width radiographically in a study. And this is the only thing I will really bother you during this presentation, and since we don't have any laser pointers here, I tried to create my own laser pointer. So if you look at this big table here, you will see here that they had only 12 implants, unfortunately, to look at. They looked at those 12 implants retrospectively, and you see the level is 0 millimeter, 2 millimeter, 4. That's how deep in the socket we are looking. 0 is at the beginning of the socket, and the deeper you go, you can see that. So we look at 12 implants, and what they have measured is this one here, the red area. The pre-operative thickness of the buccal bone, that's around 0.5 millimeter. We're talking about maxillo-anterior implants. That's what we kind of expect. It can go down to 0.3, but 0.5 is a reasonable number. So the bone has a remaining thickness of 0.5. Now, the DIBI, the DB, this is the jumping distance in these 12 patients. It's 1.5. 1.5, the magic number in dentistry. Every time you ask about numbers, say 1.5 and then you're safe, okay? 1.5, the jumping distance in these 12 implants. So if we add this together, the DOB, the yellow number, you will have the 2 millimeter, which is outside the buccal bone to outside of the implant surface. 0.5 millimeter of bone thickness, 1.5 millimeter of jumping distance. So you have 2 millimeters in these implants at the day of surgery. Now in the post-operative x-rays they took it, 3-dimensional x-rays, this is the green column, they ended up with 1.8 millimeter. So it tells us they had 2 millimeters, 1.5 of it was jumping distance, and they ended up with 1.8, so basically they didn't lose a whole lot. Maybe a little bit due to bundle bone resorption, but overall it was preserved well. So what did they do in that study? They put in a bone graft. They filled the jumping distance. Unfortunately, you see where this has been published, clinical implant research. it was not specified which implant system was used, and it was not specified which bone graft has been used. How can this go through an international review, not even mentioning what materials you used? Anyway, it's a good kind of research, but we're still lacking some knowledge there. So let's look at the meta-analysis, the systematic reviews. Kinaya did one last year, and he compared immediate implant placement to conventional implant placement, CIP, conventional implant placement. And he said no difference between those two procedures when it comes to maintaining the mid-facial buccal tissue height. Okay, let's look at this one here, Periodontology, very nice journal, systematic review. Well, you know how it goes with this systematic review, right? 12 studies have qualified for 3 meta-analysis. Only 3.5 studies actually measured the buccal gap. Interesting, yeah? We have a very important question to answer, and only 3.5 studies from these 12 actually measured the size of the buccal gap. Only 3 of these 12 studies specified which bone graft was used. Can you imagine? Anyway, they said the mid-facial recession was slightly less than in conventional implant, placement compared to immediate implant placement, so more or less the same. So you can't say you keep the buccal height better if you place an immediate implant compared to a conventional implant. They differentiated it in biotype. Well, you know, ankylosed people are not so dependent on biotypes. Since we place implants deeper in the bone, we are not too much into the biotype business compared to other implant systems which you cannot place as deep. Okay, what about Paul's systematic review from 2016? He said you have less than 1 millimeter of mid-facial recession if you place immediate implants, regardless of the biotype. I like to hear that, of course, being an ankylosed user, that you don't have to look at the biotype. Let's look at Paul's publication in eJoy. And what do we find out? 17 studies. Only 5 studies measured the buccal gap. It was between 1.4 and 2.3 millimeters. 6 studies didn't use a bone graft. 9 studies used the bone graft. And only 3 studies measured the gap and placed a graft in there. Overall, they didn't find any difference of biotypes in the mid-facial recession, and the total number was less than 1 millimeter. Well, this is a message for all those master students who want to start a meta-analysis Monday morning, a systematic review. This is from the latest issue of eJoy, Marco Esposito. I quote him: "We do not need more systematic reviews or more consensus conferences. We just need a few more clinical trials that are properly conducted and answer significant clinical questions. We have more chiefs than Indians in the meantime. We have more reviews than actual studies. So concentrate on good studies and not doing another meta-analysis." This one actually was a good study, Mario San's publication on the Astro implant. They said, yes, if you fill the gap with a slow or non-resolvable bone graft, you can keep it much better, the bone height and the bone width on the buccal side, compared to not filling the gap. So that's a good piece of research where they went exactly into those details and looked at this question. So the decision tree I was asked to give by Paul is very clear, in my opinion. Create a buccal gap, which you will have because you place a small implant diameter, and fill it with a stable bone graft. If you don't have bone on the buccal side, don't rely on having tissue. What do we want with this game? If it's only filling a gap which keeps the soft tissue up, wouldn't that be great for our patients? We place the implant, we put some graft in the gap, and that's it? What we need to keep up the soft tissues? Much better than doing connective tissue grafts and taking schnitzel from the palate and boosting the biotype in each and every patient, which you hear also from many lecturers nowadays. So the final list, to answer my 5 questions: can we place the immediate implants despite the infection? Yes, you can check it off. How about primary stability? Actually not a problem. Either choose the right implant system or the right drilling protocol. Which diameter? Small. And go to the oral side. Should we fill the gap? I think yes, we should fill the gap. And can we maintain the buccal tissue? Hopefully yes, and as you know, hope dies last. Thank you very much for your kind attention.